Moving on to corneal transplant. So corneal transplants are not just straight corneal transplants. There's various kinds based off of location. You've got your anterior corneal transplants like a DULC. You've got posterior corneal transplants like DMEC and DSEC, and we can get into that later. And then full thickness, PKP. Centration of the corneal transplant, so where it's actually transplanted, we just went over care, so that's technically a peripheral corneal transplant. The graft-host interface, which is especially important for you with the contact lens fitting, and then intraoperative complications, always fun for us, and then suture management, always fun for everyone.
And in a sense, this kind of list should give you an idea of how you should evaluate a corneal transplant. So when you look at it, think in your head, it's like, where is it? Is it well-centered? Is it not? If it's not well-centered, you'll see some interesting changes over time. And the same thing, especially the graft-host interface. They do, remember, change over time. If you have a good transplant early on, doesn't mean 10 years out it's going to be the same. And also remember, keratoconus can lead to a corneal transplant. The patient still has keratoconus, and the periphery can thin out over time as well.
I think when we think about corneal grafts, the one that comes to mind most readily is PKP, penetrating keratoplasty, which is a full thickness transplant. It seems in some cases there's a shift away from the full thickness to doing partial thickness grafts, which are including the DULC that Dr. Huang mentioned, and also our endothelial DSECs and DMECs, which we'll get to and try to touch on how that relates to contact lenses. But this is an example of a PKP, just a 2-minute video to show some of it sped up pretty rapidly, but starting off with the cautery over the diseased corneal tissue that's about to be removed.
The reason for the cautery is that it flattens. Otherwise, you have a very steep cornea, and if you then do a punch, you cut out way more tissue than you want. So flattening it out makes the next punch more reliable.
So the treatment actually suctions onto the cornea. So that's what we're talking about, trying to flatten it out so that it actually maintains suction. Because if you can see in the center, there's also 2 wires. And so if your cornea protrudes too much, it's very hard to make that contact.
This is the peripheral change. You see a little bit of bleeding. That was some neovascularization in there. This never makes us happy when the lens tries to come out of the eye, because then our blood pressure goes up, and we try to move along very quickly. Not quite as quickly as sped up, but getting the cornea on is paramount, which is why we don't like open eyes and full thickness transplants. And by we, I mean particularly I don't like them. Partial thickness is always better.
Yes.
I like watching them.
It feels a lot safer. You'll actually see the vitreous and the lens pulsate with every beat of the patient's heart as you're operating. So you can really tell that there is some real posterior pressure that can happen.
Without any irony, we call the forced 4 the cardinal sutures, because once they're in, we get much not comfortable, but more certain that this surgery will have a good outcome, because the
blood pressure goes down. Yes.
Because the chances of things going the wrong way are now down. And people always ask me, how many sutures are there in? And my answer is usually as many as it took to get this to safe. And you see this is a pretty large transplant. It was 9 millimeter. It's a good evidence of a suture leak, by the way. On the bottom there, you can see it. The orange immediately goes lighter, and this is the wound is not quite secure, so more sutures are placed in that area. But suture leaks, which happen around the suture, tend to close within a day, so I'm not worrying too much about it. But a wound leak, when the wound is not secure, that usually warrants more sutures.
Talking about other more partial thickness is going to be including DULC, deep anterior lamellar keratoplasty, which is a substantial amount of tissue still, but is preserving the patient's natural endothelium and Descemet's membrane, trying to allow that to continue its normal process, but replace as much of the tissue anterior to that as is necessary in the case. A lot of examples for this. It could be keratoconus, like we've talked about, a host of things that can cause problems, even our dystrophies, where you might have a perfectly fine endothelium and just want to remove the diseased tissue anterior to that. That's where DULC may be very helpful. This is just the portion of the surgery where it's removing the anterior surface, and then it's a very neat thing we're going to see, the grip and rip, which was my favorite. We'll see that in a moment here.
Usually a little groove is made, and the trephination is started, same with the dissection, and then the rest of the tissue can be peeled off.
There's different techniques for this as well. You probably have or haven't heard of Big Bubble. It's all kind of preference and situation.
And this is a very difficult surgery. For me, it's still probably the most difficult corneal surgery I perform, and I'm still not always happy with my outcomes. But you can see the deeper you are on the cornea, the more easily the cornea separates. You get a pretty nice stromal bed with this. But it's not always everything that you get, so ideally you would try and make sure that you're all the way down. We'll see a little follow-up pictures in how much tissue can be left over.
This might be a typical one-day post-DULC. This was a patient who just had the DULC the day before. The point I want to mention for contact lens is when we saw the patient, they had an irritated cornea. So a typical thing to do at a one-day post-op is put a soft contact lens on a bandaged contact lens. And the student asked me, is that normal? There's a bubble under there. Is that okay? Can I send him home like that? And if you haven't seen this trick, remember this trick. Take a little Q-tip and you can slide that contact lens off to the side and the bubble will disappear.
So the answer is no, don't leave the
No.
bubble there.
Yes.
And that happens with any type of irregularity in the cornea when you're placing the contact lens. So especially after a transplant, you're going to get kind of like a donut of raised tissue. That's normal. It'll eventually flatten out, but the post-op day one contact lens is very prone to bubbles just like this. So don't leave them in.
And the other trick besides moving it out of the way or milking it is placing a cannula behind it and filling it up. Almost think of the scleral lens, but on the eye.
By a month, these have resolved their clarity pretty nicely. This is a 1 month post-op, a patient with corneal ectasia, and this is with the appearance post-DALK in this particular patient.
You will see usually Descemet's folds. They're not from swelling, which they're most commonly, but just because the new tissue has a different curvature than the patient's tissue. So there'll always be some irregularities that we try and avoid as much as possible. But again, over time, they should flatten out more and more and get tighter and tighter. Overall, if there's less than 100 microns tissue back here, you tend to get a similar outcome as with a PK. This is obviously a little bit more, so we're still waiting to see if this patient will have enough of an improvement or if they need a repeat full thickness transplant. So OCT extremely helpful to assess how much tissue was left behind.
And there you can see before DALK, that inferior steepening, post-DALK, a much more regular looking corneal surface as far as the shape is concerned. Now, with a lot of these corneal grafts, we deal with sutures quite frequently. Some need to be added, some need to be removed. So we'll look at some topographies to show some representations of abnormal corneas.
And this is where, again, graft host examination is important, so all four have to make sense. You see some flattening in this area, some elevation on the front, elevation in the back, and here the pentacam just doesn't know what it's looking at. But think of the graft host junction ideally as it should be exactly matched, and if it's moved anterior, the host, or graft slippage if you want to see, then you can get flattening in that area and an elevation. Placing more sutures in that area can be helpful and tends to smooth things out more. Any tight sutures usually cause a steepening in that area, and that would tell you how to remove sutures. And then here you would usually see this is improved, it's still a little bit elevated, but you tend to see tight sutures cause a depression in that area.
So you want to remove an area where the sutures appear tight on topography. And so that's what we talk about when we do sequential removal. We're trying to minimize astigmatism later on.
This is some video footage of that actual removal process, starting with a needle to try to snip part of that suture, and that'll expose a portion of it to be grasped with some jeweler's forceps and remove it from the cornea.
And again, everybody has different techniques. Also make sure that the knot of the suture travels the shortest amount through the tissue. That's at least how I do it. And I use a needle as opposed to a blade because needle usually it's clean, it's fresh, and can be used almost like a miniature blade, the anterior bevel. Make sure you have some sort of antibiotic and disinfectant coverage, either antibiotics or iodine, just because you are creating a small corneal wound.
How much of a problem is it, and I'm asking for somebody else, a friend, if you break the suture and it gets stuck in the cornea?
It's not really a problem. Sometimes we leave these sutures in for a very long time. So as long as the suture is not exposed and is buried, then it should be fine. One way that we do this, say if you break the suture and you only get part of it out, is you can actually pull the tail of the suture a little bit, whatever is left, put it on some tension, and then use the needle to kind of trim it, and that'll actually retract back so there's no exposure or no tails poking up on the epithelium.
Thank you.
Here's another way, even though I said let the knot travel to the least amount of tissue. If there's nothing else to grab, I try and get the other side and get it out.
This patient showed up, just an interesting example of somebody who nothing was intervened yet. This just happened to the patient. They had two sutures that I was staring at. They had some irritation on the surface of their eye, history of a corneal graft, and I'm looking at that. They're saying, well, which one's really the problem? And I'll have you take a look at that picture right there. If you were at the slit lamp, which one would you remove? Suture number A, letter A, or letter B? And as it turns out, B is actually embedded deep in the cornea, to comment further on what Dr. Huang said, and that's not really irritating the surface. It's A that's the real problem. And so that's the one that got plucked out and left B, and it was fine, but the exposed one came out and the patient felt much better.
Again, think of the suture like a loop. If the front part is gone and just the bottom is in, it's deep in the cornea, it doesn't bother or will ever come out because it's underneath the surface. The front part is the issue that can break through the epithelium.
Any loose sutures, anything breaking up on the epithelium is a source of infection. So just remove it. Any irritation can recruit also new vascularization. So the cornea definitely will be happier if you remove it.
And another patient, they show up, they're feeling some irritation on the eye, you put some fluorescein on and you evaluate all their sutures, and there's one that's just glaring at you because it looks a little loose down at the bottom of the cornea. And this is what it looks like with cobalt filter. And you can see that loose suture down at the bottom, and that one is ready and primed to be removed to help the patient feel less irritated.
And any patient who wears contact lenses and has a graft with sutures, please evaluate the sutures with the contact lens off. Because I recently had a patient who said, I have irritation, but with my contact lens in, it feels great. Broken suture is obviously masked by the contact lens, but I've also had patients being sent in from an outside fitter where everything was fine. And I asked them, well, did they check your eye with the contact lens on or off? And said on. Well, then you wouldn't see a loose suture necessarily.
Dr. Huang, you mentioned concern for infection in some of these cases. I've seen that actually happen where corneal ulcer, a suture was loose and it developed a corneal ulcer right at that site. So it really does create a channel, a passageway for that infectious material to get in.
We call it a suture abscess because it really is kind of just a nice source for bacteria to kind of track their way.
So suture came out, felt better. And as far as post-suture removal, maybe infection control, I know there might be a lot of varying thoughts on how this could be done or should be done. In some cases, betadine is a very effective infection control.
And again, it depends. But if I remove the suture, it's underneath the surface. There's no breakage, there's nothing else. I tend to just do iodine and leave it at that. But anything that's loose, I definitely cover because they've had that opening for a while and there's some bacteria around probably that might have penetrated a little bit deeper.
The posterior cornea, moving on. So now we're talking about endothelial concerns. So concerns with contact lens wear, with low endothelial cell count, and then concerns we have about inducing edema.
And the challenge is usually there is a cutoff with a lot of people who fit scleral lenses where they will not fit a scleral contact lens. The challenge with that is there are patients who don't see without a scleral lens. And yes, a scleral lens might induce edema, but it might not. So how about just try it, have the conversation with the patient, because the concern about inducing edema, if that's the only way the patient can see, we can fix that. So another way, if we can offset the improvement in vision with the risk of edema, I think it's still worth it. And a endothelial cell count is just a number. If somebody is clear with 500 cells, I don't care. If somebody is foggy with 1,000, I will still do an endothelial transplant because clearly it doesn't work. When we refer?
Well, I think this is an important part for our cohort to understand. It's you find the pathology, look for something like Fuchs dystrophy, see something that is causing poor deturgescence of the cornea, and be aware of that before you put a contact lens on, because we know that contact lens will deprive the cornea of oxygen, and we're going to see edema in many cases. So this can accelerate disease that already exists. So we need to know that and communicate that to who we're referring to.
But again, trade-offs, right? There's no solution. And if a patient has edema from a contact lens, do not tell them to not wear the contact lens and then see the corneal specialist, because guess what they will say? Cornea is clear, no need for a surgery.
Fuchs dystrophy is going to be one of our most common. Of course, there's other less common endothelial problems, but just focusing on Fuchs dystrophy, the cornea is pretty amazing. The fact that the endothelium is just one single cell layer thick. And to a certain extent, it can compensate when there's a reduction to that cell count. But at some point, we talk about endothelial decompensation, where those pump cells just can't keep up anymore, and we start to see stromal edema and visual problems for our patients. This is an example. Had a patient, she was pseudophakic, said, I'm getting glare at nighttime, and I couldn't blame a cataract because she was already pseudophakic. And I look, and I really love the retroillumination coming off the iris, and you can see those little bumps. And I used to think of them as dimples, but they're really protrusions back into anterior chamber. Each of those guttae are protrusions backwards.
Excrescences, and yes, both cataract and cornea can affect the vision. Sometimes it's bad enough we do both at the same time. If a patient is uncertain or we're uncertain, let's do one thing first, cataract, and then see, we can always do a transplant later.
A little more dramatic example of Fuchs dystrophy. And we look at this all the time and we have to figure out, is this patient needing a graft potentially? This particular patient came and said, I've had problems with my cornea. Another doctor told me I might eventually need a graft. And that's something we want to talk about, is when is the graft necessary? There might even be a little buyer's remorse after cataract surgery. Somebody with Fuchs dystrophy, they get cataract surgery and they don't see very well because the corneal problem wasn't addressed.
That goes back to an old surgical saying or surgeon saying, if you predicted it before surgery, you're a very smart person. If you didn't, it's your fault.
A good words to live by. I do like that particular example because that patient did have a DMEC combined with cataract surgery, like we can see in the right eye. The densitometry looks much clearer. The pachymetry is much more normal. The left eye is the one that she had a little remorse not doing the DMEC also. Pachymetry is swollen and densitometry is opaque. So here's our keratoplasties, DSEC and DMEC.
Biggest difference is how much tissue to transplant. DMEC is only basement membrane plus cells. DSEC is stromal plus basement membrane plus cells.
And can we acknowledge, we know that there's also DSO. We're not going to talk about that now. We're going to focus on the actual transplanted tissues, the keratoplasties.
So DSO is decimate stripping only, where you actually remove the center area of the decimates, basically eliminating that irregularity of fuchs that tends to coalesce in the center and be more visually significant.
Starting with just a little view of a DSEC graft getting placed into the anterior chamber.
So it's still very thin tissue, unfolds as you can see immediately. Biggest difference is that DSEC tends to unfold by itself. DMEC, there's lots more work involved. Even there you can see that with the placement of the bubble, that graft is centered a little bit, can be recentered. Main wound is closed, but recentered from the outside. This is just a safety suture, but at the end, depending on the difficulty, sometimes the suture is placed that stays in there to make sure that the graft does not detach after surgery.
Pretty common to see post-DSEC patients with a stitch in place. How long is, we talked about stitches already, how long is that stitch staying there?
This one probably a week, or as usual, surgeon answer as long as it takes. You also see this S stamp, which is one way to identify orientation that just tells you it's the correct side up.
And a lot of things can cause, in addition to Fuchs dystrophy, corneal problems. You can have pseudophakic bullous keratopathy as an example. This, I imagine, gets a little more challenging in the operating room because now I feel like I'm seeing quite a bit of thickening and roughening of the anterior epithelium. And that needs to be removed as part of the surgery.
All of this is additional scarring that chronic bullous keratopathy causes, and yes, that would be an anterior keratectomy that's done at the time of surgery.
There, what do you see on that OCT there? I see a nice bulle right there. I was once told, I think by one of you, this is similar to what we see with a Salzmann nodule, this subepithelial fibrosis, but a very rapid example of that. Is that a fair way of thinking about this?
Yes, and there's also similar to the Salzmanns, there's a little bit of a plane there.
Yeah, exactly. So here's the plane of the belly, and in the same area, again, chronically, it's filled up with scar, and here's Bowman's, kind of the same curvature, the shape of the cornea is still maintained. So if you ignore this, you would say, oh, the cornea is pretty normal.
1 day post-DSEC, are we happy with that?
Clear cornea, the patient already sees something, small bubble. DSEC tends to have a smaller gas fill than DMEC. And the sutures I mentioned, some people place, some people don't. If I do a DSEC, it tends to be a more complicated eye, so I want to make sure that that graft does not move.
So that is a smooth post-op.
And they're 1 week, just getting even clearer. By this point, the bubble is not there anymore, can't find it in the anterior chamber, and that cornea is healing very nicely.
And the epithelium intact, and all the haze is gone.
Yes. That's before and 1 week post-DSEC. You can see anterior segment OCT, as well as the slit lamp photos there, that big improvement to the patient's cornea. Not everybody benefits as much from a DSEC as they might from a DMEC. Are there advantages to a DMEC now versus a DSEC?
Fast visual recovery, less than 1% rejection, it's repeatable. Long-term outcomes is not yet known because we're only 10 years, 15 years by now out, but it can be done at penetrating keratoplasty. I've now switched more to DSEC for the complicated cases. But yes, there are certain advantages. The recovery speed is probably the most common one. They did a comparison of long-term outcomes DMEC versus long-term outcomes DSEC 5 years out. They're very comparable, even vision loss, not rejection, but by 5 years they all look pretty similar.
So moving on, this is an actual video of a DMEC. So right here you see a scoring process. We're actually scraping the posterior portion of the cornea, trying to catch a lip to detach decimates there, and you can see that little fold. It's starting to come away. And then this is a very kind of delicate portion where you're just trying to not cause any roughening of the stroma. You're trying to kind of just isolate that decimates, and you can see it's kind of bunching up. We're going to pull it out here, and there you go.
2 little pieces.
Yep.
Oh, that came in
And
quick.
yes, it shoots right in. So you can see the difference in the quality of that graft tissue. This is paper thin graft tissue, and it doesn't necessarily unroll or open up as quickly. The other one just kind of pops open, kind of like an automatic tent, and then this is much more difficult to do in terms of getting that to we call it unscrolling, because it literally wants to curl up on itself. So this is a post-op, and what you'll see is there's some folds there, a bigger bubble, and you'll actually see a little bit. Sometimes there's still a little bit of fluid in the interface between the cornea and the graft, but overall you're seeing that it's pretty compact and the clarity has already improved.
I remember this student was so concerned because they went in the room one day post-DMEC and they said, my patient only sees counting fingers, they can't see anything, and they're looking through an air bubble.
It's the air bubble. They cannot, it's clear to you, but not to them.
Yes.
If they see anything, I'm happy. And all of them have iridotomies as well, so remember, if you see some transillumination defect, that's absolutely normal. Otherwise, the pupil would be causing a pupillary block, meaning that gas bubble in front of the pupil.
Now, by 2.5 weeks after a DMEC, I would expect a little more clarity out of the cornea than what I'm seeing here. What do you think?
Absolutely. It looks like there's an area that maybe, and it's basically an indication that there is an area that is detached. You can definitely see it better if you do a wedge right there. You can see that little line posterior is actually that graft lifting off away from the stroma, and kind of isolated edema. So focal edema in an area really points to a detachment.
Yeah, so I get the question, where is it attached? I was like, if it's clear, it's not detached. If it's swollen, there's a high chance that it's detached. OCT will help you isolate a little bit more, and here the higher magnification, you see that wave a little bit better. But please, very, 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 very high illumination and thinnest beam split you can probably get to see that little reflection.
And just to note, it is very normal for the peripheral cornea to have edema. As long as the area where the graft is clear and doesn't have edema, it's okay. But if you have peripheral edema, you have to remember that's still the patient's not so great endothelium that is out there, and eventually the better cells will populate that area. That takes a while to resolve.
And again, OCT, same image as you saw before, this detachment, we tend to judge as another assessment of correct positioning, even though you already know this is clear, so it's correctly, but the graft should curl this way towards the cornea, which sometimes makes it more difficult to attach because, well, if there's a scroll here, it doesn't matter if you push back here, that scroll will prevent the graft from attaching.
That literally looks like you just plucked a hair off my head and put it right there. That is thin tissue in that DMEC right there. You can see different angles, doing the oblique angles to the anterior segment OCT, how thin that DMEC tissue is. So we have a patient 2.5 weeks post-op. Can anything be done?
Yes, usually we place a air bubble at the slit lamp to try and reattach the graft. So again, there was no scroll, so I was comfortable putting a air bubble behind it, which you'll see in a moment, that actually reattaches that graft and pushes it up. And by now the graft is working, so as soon as it's in the right location, it will clear up that cornea and usually attach fairly quickly.
Get the air in there, trying to press that DMEC back on. Still back to that technique that we saw in the operating room with the flicking type motion on the surface to try to get that to unroll properly.
It's like ironing things out, getting the fluid out of the interface. There's a little slow strokes, and replacing some of the air with BSS so there's not too much in there, and the air is filtered. It's not just room air, it's filtered through a micron filter, so you have sterile air before you place it inside the eye.
And this patient will have to position afterwards. Just keep that in mind.
So DMEC and DSEC, the other big difference, and also sometimes helpful in choosing patients, is the patients need to be looking up for quite some time, and that can be stressful for, let's say, an elderly patient, or if they have some neck problems. And here you see that movement of that DMEC tissue, see how fine that is now in response to just an air bubble.
So was it all worth the trouble? 4 days later, they came back, and absolutely, that cornea, the DMEC is now reattached. They did very, very well, and you can see how clear that cornea is, with a little air still left in the anterior chamber, but yes, it was worth that trouble for the patient, for sure. And this is just showing, again, the DMEC before and after repositioning. You can see that small strand, and then after repositioning, it's nice and attached.
And you can see here also the reason why you see in another corneal edema the endothelial folds, because the tissue is just much thicker, and that causes that folding. Afterwards, it's nice and compact. So also, again, at one day post-op, some people ask, oh, why do they have endothelial folds? Isn't it attached? Is that edema? Well, obviously they had edema, and it's just kind of getting over that, so they will resolve over time.
Years ago, I had this patient, just to contrast the thickness of a DSEC. This was a DSEC that was dislocated, also repositioned with a bubble. You can see the before and after an anterior segment OCT. And I think it's just a nice contrast to show the difference in thickness of that actual tissue on the OCT.
Although, as you can tell, detached DSEC thicker than attached DSEC.
Because of the swelling in that tissue, because it has stroma in there. Before we leave this topic also, how is this relevant to a contact lens fitter? So now we have somebody who's fitting our patients in scleral lenses. They're seeing maybe some endothelial decompensation. At what point is it necessary to go into the operating room and get that out? Is it visual symptoms? Is it a pachymetry measurement, a certain thickness you're looking at? What really tells you that that patient needs a graft?
It's really visual symptoms. It's whether or not they're tolerating the contact lens and the swelling is not affecting the vision as much. You can't really put a number to thickness. Of course, there's, especially post-transplant, there's going to be variability in the pachymetry. So we don't want to do surgery on someone who is doing fine and has good vision.
The point is, can be also affected by climate. Let's say somebody in Arizona might have problems later than somebody in Miami just because of the surrounding area. And it's all, can the patient function well enough as they are, or they can't? And if they can't, well, they need to do something else. But let's say a patient has 6 hours of contact lens wear, then it gets too swollen, but they're fine with that. They function fine and their vision clears up after a little bit and they're fine without their contact lens, then why would you do surgery? However, a patient who only has 4 hours is blind without their contact lens. I don't think 4 hours is enough to get on with your life.
Yeah. And with any of these grafts we've talked about so far, with PKP, DSEC, DMEC, we have to start to evaluate that cornea and say, is the eye tolerating that tissue, or are we starting to wind up with a little bit of graft rejection?
So for graft rejection, we're looking out for corneal edema, keratic precipitates, KPs on the endothelium of the corneal graft, but not in the recipient cornea. And there'll be some nice pictures to illustrate that as well. Corneal neovascularization, stromal infiltrates, a cutis line, which is basically a lining up of those KP, and an epithelial rejection line, as well as subepithelial infiltrates. So Dr. Fintelman is pointing out that cutis line that's very classic for rejection. So if you see that, that is not, a detachment or anything like that. As you can see, it's very well demarcated march of KPs just in one line.
But it is similar in the sense of this area is clear and this area is foggy. And sometimes
yes.
Old rejection can leave these KPs. This is not an active one, but evidence of old. So please make note in your exam what the cornea looks like when they're fine, meaning they're clear, but they have old KP. Very good to know, because if they suddenly have 100 more, probably something is going on they should be treating. So knowing what's old, what's new, important to follow over time.
May I be picky? I see it says epithelial rejection line. Is it epithelial or endothelial? Why did I hear once cuticed as endothelial rejection?
That's absolutely correct. These are just examples of calf rejection.
Yeah.
Got it. Okay. So we're thinking about two separate things. I wanted to make sure that we're not mixing those two together. And before we leave this slide, I do want to ask, because Dr. Huang, you're our uveitis guru of many things, but keratic precipitates is what I think of when I hear about uveitis. And now we're talking about KPs with regards to a graft rejection. Is it the same process as a KP, or is that just more a general term that now we're seeing it also show up in graft rejection?
Well, it's a similar process, because you're basically talking about inflammatory cells that are coalescing and collecting on the endothelium. So any type of rigorous inflammation can result in KPs. So in a way that this is an immune response, and you'll see how we treat it is to treat it as an immune response. So it is the similar process.
And the reason why the endothelium is not working, because it's being attacked by your own body. Same reason why with a disciform keratitis you get corneal edema, because the endothelium is being attacked either by the virus or by your own immune system. Rejection rates overall, PK and DSEC are the highest, maybe around 20%. DMEC, as we said, once they're on a low-dose steroid, fluoromethalone usually for the rest of life, less than 1%. The DELC changes depending on which study you read, because they also change their steroid regimen. Some people after DELC stop the steroid as soon as 6 weeks after, which I would find pretty aggressive with any corneal transplant.
So endothelial failure, we're talking about corneal swelling, so diffuse swelling that happens. If not sure, you should definitely try steroids, because you can have a combined endothelial failure and graft rejection at the same time. Again, especially if a corneal transplant is older, the reserve for being inflamed or being assaulted by the immune system is a lot lower. And then you don't want to treat failure, but you do want to treat rejection. So keep that in mind.
And the other point is, let's say you have somebody with corneal edema. You're not sure if it's failure or if it's rejection. If you treat them with steroids and it gets better, congratulations, you treated rejection. If you treat them with steroids and it doesn't, they don't, but you didn't lose anything besides a week of steroids.
How long do you wait? 1 week? Is that
1 week. You see them back at a week. At one day, you won't see anything. All you can say, congratulations, thanks for taking your drops. Please continue. We'll see you in a week. And it's almost as a phrase, nobody should go into the OR for a transplant without having tried a week of steroids.
More examples of images of that cuticus line that we were looking at before, and you can see that just coursing right across that white line.
But you can see the age of that transplant. It looks, there's the transplants over time do develop a little bit of haze, and so it's kind of really important to see look out for these signs for a rejection that is treatable.
So again, and the other thing, remember this picture is you wanted a summary of a risk of rejection. Loose sutures, exposed knots. This is neovascularization coming in. The more quadrants of neovascularization, the worse. You have a pretty large transplant as well. If you think of this being the limbus, that's pretty close. So large transplant, episodes of pre-reverse rejection, loose sutures, and neovascularization. You have it all in this one picture.
And this is a patient that came to clinic looking strikingly similar to what we just saw. Had a PKP 1.5 years ago. I know I won't do this justice. There's a lot more going on than just the graft and the cuticus line here. In fact, when you're looking, I'll fast forward to 1 month to show you what the slit lamp looks like, but clearly the pupil is very abnormal, and there's actually a lens that's dislocating behind that, which is why it looks so abnormal. But after a month of trying the steroid, this was slowly improving, but it's a gradual, slow process.
And even when the rejections are improved, the patient can still have persistent corneal edema because the endothelium was affected too much.
And then you can see that 1 week and then 1 month changes to the cornea. Oh, go ahead.
You also see some of these KP are still here, but then they actually disappear.
Mm-hmm. And just saw this patient just about a week ago, actually. And no signs of rejection now. Cornea is looking in much better shape than it had been for the last 6 to 9 months. And this patient's feeling much better. And just image, anterior segment image. This is with the Solex, and you can actually see the lens dislocating, and that's what's causing that iris abnormality. And you can appreciate the corneal appearance as well at that visit.
Other things that can be treated both with a contact lens or surgically are iris defects. There are some iris implants you can suture, but on the cornea side, corneal tattoos can also be helpful, adding some blockage, not on the contact lens, but within the cornea, especially in patients who can't tolerate contact lenses. This particular patient had such a large defect that suturing would be impossible, and the iris, he already had multiple intraocular surgeries, chronic CME, so we decided to proceed with a corneal tattoo, forming a similar channel as you saw for the placement of the cares, opening it up with a similar instrument, and then literally placing tattoo ink into that same channel. There's a lot just basically being swept in. You can also inject it with a syringe from both sides and trying to make it as wide as possible. This patient also had megalocornea, which made everything more difficult and difficulty positioning. So overall, not the most straightforward case. But you can see afterwards that there was an improvement. He said about 70% initially. These tattoos are not stable over time but can fade, but they can be augmented later on if need be.
Is there a good way to trial the potential benefit of a tattoo with some sort of a contact lens first? Is that ever done where you put on a contact lens that's going to be opaque on the periphery?
Yes, so contact lens helps. Again, if it's poor fit, then it might not be as significant. The other thing that you can do is use a punch hole and punch a hole into either a piece of paper or a business card. I have a little punch hole occluder that you hold over the patient's pupil and say, does it improve things? And the reason why a punch hole is better than a pinhole, because pinhole is way smaller and improves way more things. Punch hole, meaning literally with a hole punch from the office, is much more, can be achieved more easily.
This is 3 months out, still stable, but at this point had a little bit more ink added, a little revision to that area to try to block a little bit more. And then later came back again, still noticing a little temporal visual disturbance, and I tried to outline for you where even a little more ink was added. And at this point, it resolved most of their symptoms, I believe, in this case.
Again, another way to improve things. No lecture would be complete without talking about keratitis and cultures, especially with contact lens. So this you don't want to see. And remember, if a patient has a very bad corneal ulcer, and comes back suddenly seeing a lot better, that's not a good sign, that's a bad sign. That means that the cornea is thinning, especially in this area. And please also notice hypopyon is here. And the three signs need to be present for a corneal ulcer is infiltrate, epithelial defect, and signs of inflammation. That can be hypopyon, necrosis, inflection, whatever you want.
Even just redness.
Redness.
And this is what we would describe as like a soupy type of ulcer where there's just a lot of sloughing of the stroma, and you're seeing that it's basically becoming very gelatinous.
Now you're making me hungry talking about soup, but not looking at this picture. So when to culture, we have to determine what's causing the problem.
I usually say, why don't you culture any atypical appearance, large ulcer, central ulcer, visual, it's significant, you should consider it. But if you use a specific technique that we'll show you right now, meaning not the classic with the C and the little plates, but Amy's, which is a culture medium, transport medium, this you can get from the lab. Make sure you get the one without charcoal, this is with charcoal, and then just a cotton tip, put it on the edges of the ulcer, and then place this. The outcomes are as good, or some would say as bad, as with a plate, because overall the culture rate is pretty low. But again, if you can do it fairly easily, these can stay in your drawer. They're good for at least a year, and usually your local lab will provide them to you for free.
I noticed you emphasized the edges of the ulcer. That's where we're going to find most of that material, the pathogen.
Usually, yes, pathogen. If you look at the previous ulcer, the chances of it being thin are much higher in the center than the periphery of the ulcer.
Okay. I just wanted to say thank you. This has been a lot of fun, and this question comes up a lot. Sounds like a question that my kids ask me a lot, but go ahead.
No, I guess overall, we hope that the relationship with ophthalmology and vice versa shouldn't just be, I said so because, and that's where the conversation ends. And even if you say it a few more times back and forth, a little more information is usually helpful.
Thank you. Please reach out if you have any questions. We'd love to hear from you and see you on campus soon.